Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning and Obesity Canada. My name is Denise Campbell-Scherer. I am the Associate Dean for the Office of Lifelong Learning, as well as a family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new Clinical Practice Guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity, and the result of more than 2 years of hard work. We acknowledge that we are on the traditional territories across Canada, the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. We are very pleased to have Dr. Jennifer Cook here today to present on prevention and harm reduction of obesity, or clinical prevention. Dr. Jennifer Cook is currently an associate professor in the School of Kinesiology and Health Science at York University. She has published over 100 scientific papers, reports, and chapters related to obesity, health, and lifestyle behaviors. Currently, her laboratory is investigating the relationship between obesity and health through clinical human studies and epidemiological approaches. In particular, she's interested in the characterization of the metabolically normal obese phenotype and is currently working on factors that identify successful weight management in adult and pediatric patient populations. This work will help to clarify the most optimal weight management strategies for maintaining and improving health.
Welcome to Obesity Canada's webinar on prevention and harm reduction of obesity, or in other words, clinical prevention of obesity. So the primary objective of today's webinar is to discuss the evidence that supports obesity prevention interventions aimed at the primary, secondary, and tertiary levels. And I'll get into what that actually means. So the aim of primary prevention is to try and prevent a condition from ever developing in the first place. And this is typically what you would think of when you think about prevention programs. In the context of obesity, primary prevention would be trying to minimize weight gain and preventing the development of obesity in individuals. So these interventions can be targeted at the population level down to the individual level. So interventions that would be examples of a population level intervention could be something like unhealthy food or beverage taxation, trying to promote healthier eating habits or dissuade individuals from consuming foods that are associated with higher risks for weight gain. You could also address social determinants of obesity, such as socioeconomic inequities and socioeconomic status, ensuring that there is legislation ensuring that individuals have equal access or affordable access to healthy foods, or interventions that are promoting physical activity through improving the built environment. So for example, improved bike lanes, walking lanes, decreased making it more difficult to park. So forcing at the population level for you to choose strategies that might minimize weight gain and prevention of obesity. At the individual level, these would be behavioral interventions aimed at individuals' choice, nutrition, physical activity programs, or interventions that address the root causes for weight gain at that individual level. So for example, an individual could have stress that leads to increased food consumption and a weight gain as a consequence. So interventions that deal with stress management might result in improved eating behaviors and decreased weight gain as a consequence. So not just targeting the eat more or eat less and move more, but the root causes for why that individual might eat more and move less. So when you examine the evidence that supports population-level interventions, it might be surprising to know that there are actually very few randomized control trials that examine primary prevention for obesity. And we'll go into why that might be a little bit later. Most studies that do examine obesity prevention examine short time periods that are associated with high risk for rapid weight gain. And there's actually very few published studies that demonstrate the effectiveness of interventions at a population level. And most of these studies demonstrate effects on eating or physical activity behavior, but it's unclear whether or not these results translate into clinically relevant differences in obesity. So I'll give you an example. So participation is an effective physical activity promotion, but that has been associated with increases in physical activity. However, it's unclear whether or not these increases in physical activity may be sufficient for reducing weight or reducing the risk for obesity. In fact, most of the evidence that suggests that nutritional therapy and physical activity may play a role in preventing unhealthy weight gain comes from observational trials. So what are some of the challenges for conducting research on primary prevention? And one of the main ones is that science is designed to see changes or differences, but not a lack of difference over time. And so if you're trying to look at the prevention of obesity, in essence, you're trying to see that there's no difference in body weight, which would mean that the comparison group would have to have an increase in body weight. And this is why most of the studies that examine primary prevention use a high-risk control group that gains a large amount of weight over a short period of time, which makes it far easier to study. In the general population, there's only a small 0.5 kilogram to 1 kilogram weight gain per year, which would mean that if you wanted to have enough power in your study, you would need a very large sample size, making the research much more expensive and thus less feasible. In actuality, obesity develops over a very long time for most individuals. And so a true primary prevention study would take a representative sample that includes these low-risk individuals that gain weight at 0.5 kilogram to 1 kilogram per year. And that on average would take about 10 to 20 years for those individuals to develop obesity. And given that research funding studies are typically less than 5 years in length, you can quickly see why this might be a challenging thing to study given our current funding models. That said, despite the fact that we have very little primary prevention research from randomized control trials, it does not mean that we should avoid counseling or using observational study evidence. And in fact, clinicians routinely provide counseling on prevention efforts for other chronic conditions despite little evidence. And here I'll use smoking as an example. So we've had several anti-smoking campaigns that have been shown to reduce the uptake of smoking and reduce smoking across the population. However, none of these studies have been able to causally link the health promotion program with a decreased incidence in lung cancer. We have observational trials that do that, but not a randomized control trial. And despite this, we still counsel individuals to decrease smoking for the purposes of reducing their lung cancer risk. Okay. And so by the same token, diet, physical activity, and other behavioral interventions have not been causally proven to be helpful for preventing weight gain or obesity. But there is substantial observational evidence, as well as short-term randomized control trials, that's suggesting that these behavioral interventions may be useful for primary prevention of obesity. So when you take a look at the primary prevention studies, they tend to be short in duration, and predominantly these studies have examined nutrition and physical activity interventions. And in particular, most of the prevention research has examined these nutrition and physical activity interventions in the context of high-risk populations who are gaining large amounts of weight in short periods of time. And today we'll be going over pregnancy or postpartum weight retention, smoking cessation, certain cancer treatments, medications that are associated with weight gain, menopause, and then weight gain in young adults. So pregnancy is a period associated with rapid weight gain, and studies have demonstrated that women retain approximately 2 to 5 kilograms of postpartum weight retention per pregnancy. And so you could quickly see how this could add up to significant amounts of weight gain for women, particularly if they have multiple children. And so this period may be a particularly important period for targeting primary weight gain prevention. The interventions that have been examined vary in their intensity and delivery methods for behavioral interventions, and it's really not clear which aspects of these interventions or in combination would be the most effective for preventing this excessive gestational weight gain. In general, these nutrition and exercise randomized control trials are associated with approximately a 20% reduction in the risk for excessive gestational weight gain. But unfortunately, the effectiveness of these interventions are not as clearly demonstrated in women with overweight or obesity. And so clearly more work is needed to develop effective interventions for preventing excessive gestational weight gain, particularly for women who may be at higher risk. But this period of time may provide a unique opportunity for obesity prevention at a stage when women are already regularly engaged with their healthcare practitioner. So smoking cessation is another period that's associated with substantial weight gain, but also substantial cardiovascular benefits. And it's important to recognize that the mortality risk associated with weight gain is in fact far less than the mortality risk associated with continuing to smoke. And so despite the increased risk for obesity, smoking cessation is going to have a net positive effect for your overall health. However, it is important to consider that post-cessation weight gain may negatively impact smoking cessation efforts, particularly in individuals of white ethnicities and those with existing weight concerns. And so preventing the weight gain associated with smoking cessation may be particularly important in those groups. Weight gain associated with smoking cessation is largely attributed to the increased energy intake and reduced energy expenditure. And the combination of smoking cessation and traditional caloric restriction interventions have had mixed results on smoking cessation and weight gain. And in particular, it is reported that strict caloric restriction may in fact impede smoking cessation attempts. The other thing to consider is that there's no long-term benefits of the behavioral interventions for weight gain prevention. So in other words, after the nutrition or physical activity intervention is over, the effects tend to subside after that with no long-term benefits. Exercise alone has been associated with improved weight gain prevention, with observational trials suggesting that individuals who quit smoking are better able to manage their weight if they are physically active. In terms of pharmacotherapy and smoking cessation, there is short-term evidence to support the effectiveness of these pharmacotherapies for attenuating weight gain post-cessation. However, it's unclear if these benefits extend past 1 year and which pharmacotherapy may be best. And in general, it appears that pharmacotherapy may delay but does not seem to entirely prevent post-cessation weight gain. So, in summary, there's insufficient evidence to strongly recommend any single type of intervention to prevent post-cessation weight gain, but the health benefits of smoking cessation are generally exceed the consequences of the weight gain associated with smoking cessation. So in terms of cancer treatment and weight gain, weight loss is by far more commonly associated with cancer treatment, but weight gain is particularly more common with breast, colorectal, prostate, and ovarian cancers. And this weight gain is thought to be related to the medications, chemotherapy, and hormonal changes that may occur during treatment for these specific cancers. And it's important to recognize that less than 10% of women who gain weight after receiving breast cancer diagnosis will return to their pre-diagnosis weight even 6 years later. And so cancer treatment may in fact be a period associated with large long-term weight gain. So in general, most studies do not demonstrate significant weight gain prevention, and none demonstrate longer lasting weight effects after the cessation of the program, again suggesting that these lifestyle management programs need to be given on a continual basis and not as a short-term basis, as the effects of the intervention appear to ebb after the intervention is over. Some studies do suggest that the outcomes may be better in postmenopausal women, and that initiating these interventions while the patient is still undergoing chemotherapy may be key in preventing the weight gain. However, the short-term negative outcomes of weight gain are less consistent than those seen with weight loss, with only increased mortality risk reported when the weight gains exceed 10%. So again, it is unclear whether or not this weight gain may be associated with negative health effects unless it is a significantly large amount of weight gain. Medication use is often associated with side effects that include weight gain, and several classes of medications such as antipsychotics, antidepressants, antihyperglycemics, and corticosteroids are associated with weight gain. The amount of weight gain they are associated with varies between the medications, but some can be a potentially large contributor to obesity. Currently, there's insufficient evidence to suggest that routine adjunct prescriptions should be given for preventing weight gain, and it's likely inappropriate from a primary perspective standpoint. However, the magnitude associated with the magnitude of weight gain associated with the use of these medications and the potential cardiometabolic consequence may warrant consideration. Of the medications that are associated with weight gain, antipsychotic medications are documented to be associated with the highest amounts of weight gain. In general, antipsychotics are thought to be related with weight gain through changes in appetite and altered metabolism, with gains approximately of 3.2 kilograms and long-term gains of up to 5.3 kilograms as compared to placebo control. However, certain types of antipsychotics are associated with weight gains as high as 10 kilograms. So, medical nutrition therapy, physical activity, and cognitive behavioral strategies are associated with medium effect sizes for weight loss trials and large effects for weight gain prevention trials. However, there's no strong evidence to suggest that the routine prescription of adjunct medicines should be used for preventing antipsychotic-associated weight gain or achieving rate reduction after weight gains. Antidepressants are associated with a more moderate amount of weight gain than antipsychotics. However, because there is a higher prevalence of antidepressant use, there may be a higher global burden of weight gain associated with antidepressants than with antipsychotics. What is important is the monitoring of weight changes are needed early, as these early body weight changes are highly predictive of long-term weight changes, and then considering early intervention in preventing excess gain if possible. Weight gains associated with antidepressants may also be associated with underlying mood disorder changes. And so, in other words, what this could mean is that it could be that changes in the depression itself is associated with increased appetite and weight gain, as opposed to the antidepressant itself causing the weight gain. So it's important for the clinicians to be cognizant of this. It is also unclear whether medical nutrition therapy or physical activity therapy is effective in preventing weight gain associated with antidepressant use, particularly in populations without obesity. So weight gain is associated with untreated illness as well, and so whenever possible, engaging in these healthy nutrition and eating behaviors and this weight monitoring may be important when initiating and continuing treatment of depression. In terms of diabetes medication, most individuals with type 2 diabetes already have obesity, and patients are recommended weight loss to improve risk factors. However, some diabetes medications are paradoxically associated with improved insulin sensitivity and weight gain. TZDs, sulfonylureas, and are associated with weight gains of approximately 1 to 4 kilograms, and insulin is associated with slightly higher weight gains of 5 to 6 kilograms. And the mechanisms responsible for the weight gain vary between the medications, but include increases in appetite, increased lipid storage, and fluid retention. Patients who are prescribed sulfonylureas as the first treatment strategy typically will have greater weight gains than with other diabetes medications. Metformin is the most commonly prescribed first-line treatment option, which is associated with modest weight losses, and it may help prevent some of the weight gain associated with the use of other type 2 diabetes medications such as insulin therapy. So menopause is another period of life that is traditionally thought to be associated with greater age-related weight gain. In reality, menopause is associated with normal rates of weight gain, but significant changes in body composition that may not be apparent through the scale. In particular, menopause is associated with rapid losses in muscle mass that is accompanied by accelerated gains in fat mass. Menopause is also associated with behavioral changes such as increases in sedentary time and physical inactivity that may further exacerbate the loss in muscle mass and gains in accelerated fat mass, and also result in increased cardiovascular risk. Despite the beneficial effects of hormone replacement on body fat distribution, it should not be recommended as a treatment for abdominal obesity due to the increased cardiovascular risk associated with hormone replacement therapy. In general, lifestyle intervention has been shown to be successful in preventing weight gain over a 5-year period in women transitioning to menopause, but more research is needed to determine which components are most important in preventing menopausal-related increases in adiposity. Early adulthood is also another life phase that is associated with increased risk for weight gain. It's reported the average weight gain during early adulthood is approximately 14 kilograms over 15 years, which is at the high end of the weight gain that you might see in the general population. So onset of obesity is common in this age group and thus may represent an important life stage to target when considering obesity prevention initiatives, particularly for young adults who are attending post-secondary education who are reported to have significant weight gains during that period. Most of the literature that examines obesity prevention in young adults are in fact weight loss studies or weight loss maintenance trials or observational studies. In general, the interventions are very diverse with nutrition and physical activity approaches, behavioral change strategies, technology-based programs, and educational programs, but they generally are quite disappointing, with several reporting no effect of this intervention on weight gain prevention. So interventions that typically do demonstrate significant effects in young adults are typically weight loss studies, and overall they show modest results of less than a 2 kilogram difference, with very little evidence to suggest that this weight loss is maintained long term. And so young adults may be a particularly high risk group for weight gain with poor primary prevention intervention success. So clearly more research is needed to demonstrate what types of interventions might be effective for preventing weight gain in young adults. So now let's move on to secondary prevention. So secondary prevention aims to reduce the impact of the disease that is already developed. So early detection and treating the disease as soon as possible in order to slow or stop its progression, and if possible to return the patient to their original health and functional status to prevent long-term problems. So in the context of obesity, this would be to have early detection of weight gain and early detection of the development of obesity, and treating the obesity as soon as possible in order to prevent or slow its progression to obesity with other chronic conditions. So the regular screening and preventing of further weight gain in individuals with uncomplicated obesity would be extremely important. One of the tools that can be used to screen obesity and the severity is the Edmonton Obesity Staging System. or EOS. And in individuals in stage 0 or stage 1 would be individuals with no or subclinical risk factors or physical symptoms, psychological symptoms, or functional limitations associated with their obesity. And again, for these individuals, because of their mild or uncomplicated obesity, the regular screening to prevent further weight gain may be crucial for these individuals. So it's important to recognize that obesity is associated with increased morbidity and mortality. However, there's substantial variations in the health profiles observed between individuals with the same body mass index. So, for example, there might be two individuals with a BMI of 32. One has no functional limitations, has not yet developed hypertension or diabetes or any of the cardiometabolic risk factors that you might expect. While another individual with the same age, same sex, same profile, but has hypertension, dyslipidemia, osteoarthritis, and then other obesity-related comorbidities. And the variation in morbidity is more common at that lower border of obesity, so in that class 1. And so it's important to assess individuals in that lower, particularly in that lower obesity class, because a significant portion of that population may present with an elevated body mass and yet can be described as what we call metabolically healthy. And depending on the definition used, up to 40% of the population could be defined as being metabolically healthy. If we were to use the Edmonton obesity staging system, which accounts for not just physiological but also psychological and functional limitations, the prevalence of individuals with an elevated body mass index that can be described as healthy might be approximately 20 to 25%. So questions that still remain are whether or not these individuals with metabolic healthy obesity have better long-term health outcomes as compared to individuals with obesity and obesity-related complications. There are individuals, researchers that would believe that this is a transition stage and they're simply on their way to developing obesity-related conditions, and so the same treatment strategies should apply. In general, individuals with metabolically healthy obesity tend to be more physically active, and there are less consistent evidence to report dietary differences. But it may suggest that behavioral strategies may play an important role in secondary prevention. So a part of secondary prevention is the early detection and monitoring of risk factors. And so this brings up the importance of self-weighing. Regular assessments of obesity and weight gain need to be addressed early in order to make sure that interventions are promptly addressing the causes of weight gain. And currently there are no randomized control trials that examine regular self-weighing in a primary or secondary prevention context. There are observational trials such as the Pound of Prevention trial and Stop Regain trials where individuals who engaged in self-weighing had less weight gain over time. And in the context of weight loss or weight loss maintenance, self-weighing is also associated with better weight outcomes. However, in populations with severe obesity, regular weighing may be a source of stress and frustration that needs to be considered on an individual basis with the patient. And so the clinician should initiate respectful conversations around weight and weight gain for their patients with and without obesity. In terms of tertiary prevention aims at softening the impact of an ongoing illness or an injury that has long-lasting effects, helping people manage long-term, often complex health problems and injuries in order to improve their function and their quality of life. For obesity, this would be synonymous with weight loss and long-term obesity management, and is the topic of the other chapters within the guidelines. And so I will not address them here. So in summary, the key messages for healthcare providers are that it's important to recognize that obesity is a heterogeneous disease that can develop via slow and steady weight gain over an extended period of time or from rapid bursts of weight gain. So regular assessments of body weight are needed in order to catch early weight gain, and the use of the Edmonton Obesity Staging System will help you evaluate if a patient has obesity. Clinicians should initiate discussions around weight gain early and contemplate interventions that consider the complex causes, providing guidance beyond the eat less and move more. Many medications are associated with weight gain side effects and can contribute to longer-term weight gain. So excess pregnancy weight gain and post-pregnancy weight retention are significantly reduced with behavioral interventions. And so clinicians should counsel women attending prenatal care not to exceed the pregnancy weight gain guidelines, and also give pregnant women the necessary counseling as well as dietary, physical activity, and psychological interventions within their prenatal visits in order to prevent excess gestational weight gain. It's also important to consider that the health benefits of smoking cessation outweigh the cardiovascular consequences associated with smoking cessation weight gain. But it's important to address weight gain concerns for individuals, as that may negatively impact their smoking cessation efforts. Short-term behavioral interventions, generally 6 months or less, are aimed at preventing weight gain in young adulthood. Menopause and smoking cessation and breast cancer have not been shown to be effective long-term, and longer-term interventions will likely be needed in order to properly examine strategies for preventing weight gain for many of these high-risk groups and the general population. In terms of people living with obesity, it's important to consider that preventing or delaying obesity is likely easier than long-term reduction. And it's important to remember that the causes of and the risk factors for weight gain are wide-ranging, extending beyond personal lifestyle choices such as food intake and exercise, and include factors that you may or may not be able to control. So obesity can develop through small gains in weight over a long period of time or from rapid bursts in weight gain. And the average weight gain in Canada is about 0.5 kilogram to 1 kilogram per year. However, people are prone to greater weight gain during certain life stages such as adolescence, young adulthood, and then pregnancy. You should raise your weight concerns with your primary care physician, even if you have experienced a modest weight gain. And regular weighings by your healthcare providers can help identify patterns and factors that may be contributing to weight gain early. So thank you for your time.
Awesome. Thank you so much, Jennifer. That was so interesting. And we're really pleased today that we have Dr. Laurie Twells and Dr. Arya Sharma joining us for the panel. So Dr. Laurie Twells is a professor in the School of Pharmacy and Faculty of Medicine at Memorial University, and is a clinical epidemiologist with expertise in health economics, epidemiology, and health policy. She is the principal investigator of a translational research program in bariatric care at Memorial University, and has published over 50 articles in areas including the epidemiology of obesity in Canada, the prevention of childhood obesity, patient expectations of weight loss after bariatric surgery, complications of bariatric surgery, clinical outcomes of health and health-related quality of life post-bariatric surgery. She's currently conducting research on obesity, exercise, and infertility, maternal obesity and asthma, and theory-based applications to support behavior change in adults living with type 2 diabetes. Dr. Twells has been a member of Obesity Canada since 2009 and is a fellow of the American Obesity Society. Dr. Sharma was recruited from the Humboldt University Berlin, Germany in 2002 to a Canadian Research Chair, Tier 1 in Cardiovascular Obesity and Management at McMaster University. And in 2007, he accepted a position as professor and chair in obesity research and management at the University of Alberta, where he is also the medical co-director of the Alberta Health Services Provincial Obesity Program. In 2005, he spearheaded the launch of the Canadian Obesity Network, now Obesity Canada, which has remarkably transformed the landscape of obesity research and management in Canada. And his research focuses on evidence-based approaches to managing patients living with obesity, including the development of the Edmonton Obesity Staging System. So welcome, Laurie, Arya, and Jennifer. We have a busy chat box. So I think we should kick things off with just a question that's at the top here, which is many people have argued that obesity prevention should not be done at all because it can contribute to weight bias and obesity stigma. Um, so that's a great, interesting question. Does anybody want to try tackling that one?
Denise, I just have a comment. It's Laurie Twells.
Laurie, yeah.
Hello, everybody. It's great to be on the panel. I mean, I guess if we just go back to the definition of obesity in terms of it being excess body fat or adipose tissue impairing or, you know, a disease in itself, from the perspective of it causing weight bias and stigma, if we look at other chronic conditions and the way we deal with them, we're quite happy to try and prevent things like type 2 diabetes, cardiovascular disease, cancer. And I know we don't necessarily have all the stigmas that go along with those other conditions, but I think we do have to stay true to the fact that obesity by definition is a chronic disease itself. So really what we're trying to do is prevent a chronic disease and actually ensure, or at least encourage people not to develop, you know, kind of health issues and health impairments that come with excess body fat, independent of size. You know, I think the focus always needs to stay on health. That would just be my first thought there.
Mm-hmm. No, thanks, Laurie. That's really excellent, comprehensive answer. Did Jennifer, Arya want to chime in on that?
Sure, it's Arya here. Hi, everyone. So yeah, I agree with Laurie. You know, when we talk about obesity prevention, very often when you talk about the measures that people are talking about, which is eating balanced diets and increasing physical activity and those kind of measures, you know, you could argue that those are not really obesity prevention measures. I mean, those are measures that you would like the population in general to adopt, irrespective of what their body weight is. I mean, everybody is going to benefit from, you know, from eating healthy and from being more active and from getting better sleep and, you know, and all of those kind of recommendations. So framing them as obesity prevention programs really is a disservice. Also in the sense that, you know, then, you know, people who don't see themselves as having obesity, or people who see, well, I don't have a weight problem, so I don't actually need to do any of those things, is also not the message that you're trying to send, because all of these behaviors at the population level, you know, have a lot of benefits for the population, you know, that go beyond simply controlling weight. And you might even argue that if somebody eats a balanced diet and is physically active and is otherwise, you know, has good health behaviors, then even if this person, you know, gradually gains some weight over the years, that might not even be, you know, that detrimental to their health. So I think the framing of how these programs are put out there and how they are promoted and how the success of such programs is then evaluated has a lot to do with the question of whether or not such programs are going to, you know, promote weight bias or lead to, you know, weight obsession and unhealthy behaviors.
Mm-hmm. Super. Yeah.
Yeah, I completely agree with everything that Laurie and Arya have said. And I think that the framing of how you do obesity prevention is really key. And it's really for everybody, because, you know, as a population, we're all gaining. And so all of these lifestyle strategies that are going to promote health and obesity prevention should be for everybody, and not just targeting people who are close to developing obesity.
Mm-hmm. Okay. Well, and I think there's a related question here, and I don't know if there's much more to add, but it's sort of more directed at clinicians, and sort of that some clinicians don't agree with checking patients' weight regularly. And what evidence would we suggest to counter those views?
So in terms of randomized control trials, there isn't a lot of evidence. You know, observational research would suggest that monitoring your weight is associated with better weight outcomes over time. But, you know, from a monitoring standpoint, you know, if we, you know, agree that obesity is a chronic condition that tracks over time, then how would you track the progression of the disease without weight measures? Because ultimately it is associated with increased body fat. And I'm not suggesting that you do it for again, just your patients that are at an elevated weight that are close, but for all your patients, because ultimately, I think all of us can benefit from, minimizing our weight gain over time and eating healthier and being more physically active. And so these are questions I think that all of us should be discussing with our clinicians.
Mm-hmm.
Well, I mean, what I would add to that is that weight, although an individual weight or a given weight does not really tell me much about the health of a patient. So if I take a patient and I put them on a scale and, they weigh 65, they weigh 120 pounds or they weigh 160 pounds, I don't really know how healthy that person is. So I can't do much with a single weight measure. But what is vitally important are, of course, changes in body weight. And changes in body weight, it turns out, are actually most alarming when they go down. So, one of the most alarming signs that you can see in all of medicine is actually non-intentional or unintentional weight loss. So when a patient is progressively losing weight and nobody really knows why, that is not a good sign, and that patient has to be worked up, and we have to do a lot of tests in those patients to try to figure out what's going on. And on the other side, when a patient continues to gain weight and is gaining more weight than you would expect, or is clearly trending upwards, it's that change in body weight that should then prompt investigations, etc. So, and the issue with that is, I mean, you can't know whether someone's weight is going up or down if you don't have a baseline weight, right? And if you're not monitoring the weight. So it is, it is something that has that. So regular weight management, weight measurements carry a lot of important clinical information, both whether the weight is going up or the weight is going down. I mean, that's important to know. Now, how you deal with this in practice, again, is a different story. I mean, first of all, obviously, the weighing itself has to be in a private room. It needs to be done tactfully. You need to ask for permission. You need to be very non-judgmental about measuring weights. You can ask the patient, okay, we're going to measure you. Would you be open to knowing the number or not? So a lot depends on how you do it and how it is done. So, I mean, I've rarely encountered a patient who, once you explain what is going on and why you're doing this and do it properly, would totally, refuse to being weighed. But it is a vital, indicator. It doesn't mean that you have to do it, constantly at every visit. But taking someone's weight, I would consider as important as taking someone's blood pressure or body temperature or other things that we measure routinely in patients, because that's how it's, in some way it is a vital sign.
Mm-hmm. Yes, absolutely. And I think that's just such an important plug to go back to the weight bias chapter and the assessment chapter around how you ask this question, right? So asking respectfully to see if people are open to being weighed is really important, and doing what patients want. But hopefully, following the guidance of that chapter, people can have better conversations with people over time about these small incremental changes. And that kind of leads into the next question, actually, which is, how can clinicians open the discussions about small amounts of weight gain over time? Are there potential harms with that? And what's the clinical experience people have with that?
Well, I mean, it's always helpful to have a discussion about when the number changes, either going up or down. I think that is always worthwhile having a discussion, because sometimes it means nothing, right? I mean, the question here is about small changes in body weight. What you actually find much more frequently is people are alarmed about large changes in body weight that happen in very short term. And so patients get very alarmed. They step on the scale in the morning, and they're 140 pounds, and then they step on the same scale in the evening, and they're certainly now 150 pounds. So that's a 10-pound weight gain during the course of the day. And they get totally alarmed, and then they tell you, well, I haven't eaten anything all day. I have no idea how I could gain the weight. While explaining to them that is actually fluid, and that's not body fat, and that is just fluctuations in body fluid that happen. Is often very helpful. And that's actually also one of the reasons why you would tell people not to weigh themselves every day, especially if they experience those large excursions in body weight, because it's important for patients to understand that what you're weighing is not just body fat. A lot of the change in body weight can be attributable to fluid retention, especially in older people. I mean, this might be less of a problem in younger patients, but as you start looking at older patients, a lot of those fluctuations, those day-to-day changes in body weight have nothing to do with energy balance. That is largely fluid balance. And so you have to take that into consideration, and you have to also explain what that means to your patients.
Okay. We have an interesting question here about genetics and whether or not there could be some sort of a role of what we're learning about genetics with obesity prevention. Anybody feel comfortable to comment on genetics of obesity and how that's related?
Well, it's Ari here. So again, there's no doubt that that genetic predisposition is highly prevalent in the population. I mean, we now have hundreds of genes that we know of that are related to body weight, and a lot of these variants are pretty common. And probably if you just have one or two of them, it doesn't really mean much. But when you start, but they're additive, right? So the more of the more of these genetic variants you have that promote weight gain, the easier it's going to be for someone to gain weight when you expose them to the same environment. I mean, ultimately, you must say, we all live in the same environment. We all have the same access to, fast food. We all have sedentary jobs. We all do the same thing. And yet there's a lot of variation in body weight across the population. And the explanation for that variation in body weight is more genetics than it is different environments, because the environments are pretty much the same for most people. So it starts with that, and that is an important aspect to say. So, and you can see this in families. I mean, one of the questions I ask all my patients is, this weight issue, which side of the family does it come from? Is it on your dad's side or your mom's side? And very often they'll tell you, it's my mom's side more, or it's on my dad's side, or it's on both sides. So there's a very strong, and there's a lot of data that supports this, that the genetic predisposition plays a huge role. Now, the argument that you then often hear is, well, but the genes haven't changed, and we've seen this increase in obesity in the last 30 years, and the genes haven't really changed that much. Well, to make things a little bit more complicated, it's not just the genes, which is sort of the DNA coding that that might not have changed, but today we understand that there's this phenomenon called epigenetics, which means that there's DNA modification, which doesn't really change the genetic code, but it does change whether or not certain genes are expressed in certain tissues. And that can change very quickly. In fact, epigenetic changes to the DNA code happen all the time. And in the context of obesity, we know that some of these changes, especially those related to energy metabolism and energy regulation and appetite regulation, might happen very, very early in life, and they might actually happen, in the womb and in the early period after birth. That's where a lot of these things get programmed. And that can change within one or two generations, right? So the argument that this vast increase in obesity that we've seen in the population is not related to genetics just does not hold, because we can actually see those changes happen very rapidly in populations. By the way, not just human populations. I mean, that's a phenomenon that goes pretty much across the animal kingdom. So it does play a role in that sense, which on the other hand then doesn't mean that you can't do anything about it, because it just means that the efforts that someone who has a stronger genetic predisposition will have to do in order to control their weight is going to be much more intense, or it's going to take a lot more effort than for someone who's not. And just to point out the importance of this, I mean, we probably all know people at the other end of the spectrum, so we know these people who are extremely skinny, and and when you look at their lifestyle, they have horrible lifestyles. They're eating vast amounts of calories. They don't exercise, and yet they stay thin as a rail. So we know that is also very genetic, right? So in the same way that there are genes that predispose to obesity, there are also genes that predispose to skinniness, but those genes in the population level are far less frequent, but they exist, right? So there is a role for genetics, and I think that's really important to understand, because that also then ties into this whole self-blame and saying, obviously someone who has a strong genetic predisposition for obesity is going to have a much, much harder time living in this obesogenic environment, controlling their weight, than someone who has the skinny genes. So I think it's an important topic, and it's something that always gets forgotten in public health messages. I mean, there's never any talk about it when the evidence is quite clear that body shape and size is highly genetically determined.
Just to jump in there.
Do you want to chime in? Yeah. I saw you there.
Just to add to what Arya was saying, I mean, it's interesting because with the bariatric surgery, we're following some individuals who've had bariatric surgery who've then since gone on to get pregnant as well. And just looking at that research. So exactly what Arya is saying, the gene expression can change, not just in generations, but in a person. So when you look at the sort of genetic expression of some of these genes associated with obesity before people have bariatric surgery and afterwards, the gene expression has changed. So with weight loss of up to towards say 100 pounds or 50 kilos in the first 12 to 18 months post-surgery, their gene expression has changed, and the risk of actually those children going on to develop childhood obesity is reduced. So we do know that actually reducing body weight, it's certainly in that population of people who are living with severe obesity, does have a positive impact on not only themselves, but the next generation. Could be considered almost like an intervention to prevent childhood obesity if it was to that extent, but there's very few, there's very small numbers of people getting pregnant after bariatric surgery. But it does tell us a lot about how excess adipose tissue changes our genetic profile. And we do know that if one parent is living with obesity, the increased risk of childhood obesity goes up about 50%. But if two parents have it, it goes up significantly to 80 to 90%. So it's the environment hasn't doubled, but the genetic impact is doubled pretty much. So we do know genetics plays a big role actually in obesity.
Do we know, Laurie, that's fascinating. Do we have any data about what happens with gene expression with significant weight loss with some of the new medications, or is it too premature?
I think it's probably too premature. I don't know. I've seen the genetic studies primarily come out of Quebec in the bariatric surgery cohorts there. I haven't seen the same impact in terms of medication use. But again, you've got to look at weight loss. And I mean, this would be interesting actually. But, if you look at the average weight loss in the first year post-bariatric surgery, on average, it's about 100 pounds, we'll say. If you look at medication, it's probably 15 to 25. So it's significant in terms of health outcomes and changing, reducing some of the adverse health effects, but actually the amount is not as much. So that'd be interesting to see whether that genetic profile does change. But it certainly changes after bariatric surgery, and it may not just because of weight loss, it may because of some of the other metabolic changes that have gone on around gut hormones, etc., which we know lead to a decrease in type 2 diabetes within the first few days post bariatric surgery. So there's something a bit different about bariatric surgery, I think, than probably medications. But that would be interesting to see whether or not there was a sort of gene expression change over time post anti-obesity meds.
Yeah, interesting question. There's another question here that talks about obesity developing over long periods of time and the critical points in a person's life where we could focus on prevention of weight gain. And some of them were mentioned, Jennifer, in your talk, but I know both you and Laurie have thought about this as it relates to pediatric obesity. And I know we have another guideline coming down the pipe for pediatric obesity, but just wondering if you have any thoughts on that as it relates to kids?
Yeah, I mean, the monitoring of normal growth in youth is obviously very important because it really sets the trajectory for their obesity risk later in life. And particularly just that young adolescence, young adulthood is a really important time as well. But that is the time period where most of us don't see our physician on a regular basis. So I'm not sure that it should be, or it can be the clinician's roles, because I know that, when I was in university, I only saw my doctor to get a doctor's note for missing an exam. So it would be a challenge to push that, I think, on that period. I think, pregnancy is a really big one for young women where there's significant weight gain. And I think that we have to definitely do more in that area to make sure that women are not gaining too much during their pregnancies, because that will definitely, large impacts on their future health.
We could also have a whole session on menopause, Jennifer. Let me just say, there's a whole session that could happen on menopause. I think you can gain weight with 12 saltine crackers a day, I tell you. So,
Denise, I just add a little bit there, not necessarily the pediatric piece, but I know it's something we've talked about before, and I know, Ari, you published a paper on root causes and things, but some of this qualitative work we did around patients who were eligible for surgery, whether they went forward and had it or not, really spoke to life's events as well. So we do have certain times in life when we should be looking out for weight gain, absolutely, whether it's pregnancy, menopause, smoking cessation, etc. But there's other things that cause weight gain. So for example, a change in employment. You might go from a very active manual type job to a sedentary sitting job. Stress in your relationship, whether it's a separation or divorce. Some sort of sleep interruption related to potentially stress or something that's going on in your life, we know can increase the likelihood of weight gain. Changing your environment, new medication. Maybe you go on an antidepressant, for example. So I think these are also other things that we know are some of the predisposing factors for weight gain. And they're the sorts of things you probably should be talking about with your physician, but we may not always think about them because these are things that are absolutely associated with, if not causal, for gaining weight.
mm-hmm. Excellent reminder, Lori. Thank you. Yes. So we've got just a couple of minutes here. There's an interesting question here about people who are metabolically healthy but have excess adiposity and how people could maintain that low EOS state. Does anybody want to chime in on that? I think we covered a little bit about it, but.
Well, Jennifer should probably speak to this because she's actually done quite a bit of work on this. So maybe Jennifer, you can answer that, and then I have a couple of comments on this issue. But Jennifer, this is your area of expertise.
Yeah. So when you take a look at the literature, the most common differences that you see with this metabolically healthy phenotype is that they typically are a bit younger than those with your typical obesity-related chronic diseases, and they tend to be a little bit more physically active. In terms of the diet, you don't really see consistent differences in what they eat or how they eat, but really that physical activity piece seems to be really important. And we know that physical activity is associated with a lot of health benefits, but in terms of weight loss, it is not a very effective strategy because it's just you have to do so much exercise in order to get a significant caloric expenditure. And so I think it just reminds us that things that are good for our health may or may not show up on the scale, and those are two entirely different things. I think that we should all strive to be the healthiest that we can be at no matter what weight we're at. That goes for the people from at BMI 20 all the way up to BMI 60. And I think that we all need to be cognizant of our genetic profiles and, our lifestyles and the other things that we have in our life, and to do the best that we can at whatever weight we are.
Mm-hmm. That is a really great note, I think, to wind up on. Ariad, you've got a couple thoughts on that as well, and we'll give you the last word.
Well, so I fully agree with what Jennifer just said, that, very often what you see is when people are metabolically healthy, they tend to be younger, they tend to have at least a lot more physical activity. I mean, the one thing that is undisputed is that as people get older, their risk for complications goes up. So yes, you might be metabolically healthy now, but that doesn't mean that you're still going to be metabolically healthy 5 years or 10 years or 20 years down the road, especially if there's a change to your level of physical activity or anything else happens. I'm just talking about all of the life events that can happen. So it is very easy for someone who's now metabolically healthy to, then become metabolically unhealthy. And that risk is certainly higher than for someone who's not in that state. But but there's no doubt that people can be pretty physically, pretty healthy across a wide range of body shapes and sizes. And so, this comes back to to what we've often talked about, is that we should not be diagnosing obesity based on body mass index or body weight alone.
Mm-hmm. Mm-hmm. Yeah, absolutely. Well, folks, I can't believe an hour has gone so rapidly. Thank you so much, Jennifer, for the fantastic talk and to you and Lori and Sonia Wicklum for your efforts on this great chapter. And thanks also to Aria and Lori for supporting Jennifer with the panel work today, and to all those who attended. And we've just really enjoyed these webinar series, and really appreciate also how many people are downloading them after the fact as well, which is just great. So we certainly appreciate your feedback. There's a feedback form on the screen. If you have a minute to give a little bit of feedback on this, that would be super helpful. And we look forward to seeing you next time.